Greetings all, this is Miss Gibson. So this will be your final lecture for the urinary system. I know that my videos or my lectures have been short and sweet. I do that on purpose because I know you guys lose interest and I don't want to sit and talk for an hour just for you guys to not get anything out of it. So once again, look at your resources. I've spent a lot of time pulling all of those to put them there for your guys' benefit. Email me anytime. My office is always open. If I'm available, come right on in. We'll figure it out together. So we're going to talk about renal replacement therapies. This is a therapy that replaces the normal blood filtering function of the kidneys. It's used when the kidneys are not working well, of course, which is called renal failure. And it can also include acute kidney injury or chronic kidney disease. Things like intermittent hemodialysis is the most common RRT, or renal replacement therapy. Here are your objectives. Hemodialysis, they're going to have a fistula that goes in the arm. This is where you're going to listen for, In hemodialysis, the blood circulates outside the body and goes through a machine with special filters. The blood comes out of the patient through a flexible tube known as a catheter. The tube is inserted into the vein. Like the kidneys, the filters remove the waste products from the blood. The filter blood then returns to the patient through another catheter. This works like an artificial kidney. So your intermittent hemodialysis, this is delivered over 3 to 6 hours. It uses a machine to mix and monitor the fluid that cleanses the unwanted particles of the blood, which is a disalate. This is delivered 3 to 4 times a week, and the urologist will give you an order for that. The procedure it's a temporary hemodialysis dual, which means 2, lumen catheter, or a sub-Q device is used until provider places a more long-term device. There are 2 common choices. You have a internal arterial venous fistula, or an AV fistula, which is this, or you have an AV graft, which is over here. Pull that down. These are surgically implanted. The AV grafts are used when the fistula has not developed. A graft is a man-made tube that is inserted into your arm to connect an artery to a vein. Grafts can usually be used for dialysis within 2 to 6 weeks. Of course, we know that we want to avoid taking blood pressure, administering injections, or performing venipunctures or IVs in that arm where the graft is. After placing the device, you want to, after the doctor or surgeon has surgically put the device in there, you're going to reduce swelling, make sure you're checking vitals before and after, and then your good client education on signs and symptoms of infection. Complications with your AV fistulas. The common causes are going to be your thrombosis or stenosis, infection, aneurysm formation, ischemia, and heart failure. So the thrombosis is the most frequent problem, so anticoagulants are given to prevent that. Most infections are caused by staph infection introduced with cannulation. The skin is cleansed well before insertion. Ischemia happens with decreased arterial blood flow to the area below the fistula, which is called Steele syndrome. Signs are cold, numb fingers to gangrene fingers, where the fingers have actually turned black from lack of circulation. Make sure that you look at the resource on the Still syndrome. That way you're just familiar with it. Let's see. Hemodialysis nursing considerations. You're going to check for hypotension, anemia, infection. Let's see what I need to talk about. This disequilibrium syndrome is a result of too rapid decrease of BUN and circulating blood volume. It can result in cerebral edema and can cause increased intracranial pressure. Early recognition is essential, which includes nausea, vomiting, changes in level of consciousness, and seizures. Patients that are advanced age are at an increased risk. Nursing action is to use slow exchange rate, especially with older adults and your first-time hemodialysis patients. The doctor will probably order anticonvulsants as well as a barbiturate to help with that. Let's see. Peritoneal dialysis, this involves installation of hypertonic diacylate solution into your peritoneal cavity. Then it drains the diacylate solution, which includes waste products, out. The solution goes in and then comes out. There's 3 parts. You're going to fill when the diacylate or fluid for dialysis is going into the peritoneal cavity. It will dwell there when the diacylate is remaining inside. Infiltration is occurring, and then you're going to drain. So the drain is when the diacylate is being removed from the patient. So you have a fill, F-I-L-L, dwell, and a drain. Peritoneal dialysis is slower than hemodialysis and more time is needed. However, it can be done at home. Another problem is it pulls protein in the outflow liquid, which can increase risk for peritoneal injury and discomfort. So some indications of the peritoneal dialysis is it can be indicated for patients as a treatment of choice for older adults who need dialysis. The advantages of this peritoneal dialysis is any patient that cannot take anticoagulants can do peritoneal dialysis. If they have difficult vascular access or have chronic infections, unstable chronic illness such as diabetes, heart failure, and severe hypertension, it can be done at home, but it does take a little bit longer than the hemodialysis. Advantages and disadvantages, I'm going to let you guys go over that. This is what the peritoneal dialysis looks like. Like we said, it can be done at home. The cycler assisted peritoneal dialysis is a machine that does the exchange. It's usually done at night while you're asleep. You can connect your catheter to the tubes, go into the machine called a cycler. The machine does your exchanges for you. It will fill your abdomen with diacylate, wait for the correct dwell time, and then drain the used diacylate from your abdomen into a bag. The continuous ambulatory peritoneal dialysis, this exchanges is done by hand using gravity to help fill your abdomen with diacylate and drain it once the dwell time is over. These exchanges are called manual exchanges because you need to do each exchange yourself. This type of peritoneal dialysis must be done during the day. Make sure that you're looking at your resources as well for these. Let's see, let's move on. For the procedure, I'm going to let you kind of read over this, but if you work in a dialysis clinic, you know that you'll want to get your dry weight without the dilate before you do the before they get dialyzed. You're going to do some blood work. You're going to determine the patient's ability to perform the peritoneal dialysis. You're going to assess for pain and do your education on how to do it, when to do it, what signs and symptoms of infection. It's usually 30 minute exchange repeated over 8 to 10 hours while client is asleep for the CCPD, which is what we just talked about here. Here's your nursing actions. I'll let you guys look over those. Your post-procedure, you're going to monitor the weight in the labs afterwards as well. So you've weighed on before, which is your dry weight. Then your wet weight will be after. You're going to do your education, instruct your family, teach to follow instructions. Let's see, give support. A lot of times that can be very depressing to have to do that. There'll be a lot of questions. So there are actually groups out there that patients can go to or do web calls with as well. Some complications. Peritonitis is a major problem caused by connection site contamination. You want to use a sterile procedure to do that, to prevent those infections. Pain during inflow is common, so you want to warm. If you can warm the diisolate, that's a big help. Infection at the exit site or the tunnel can also be an issue. Protein loss, hyperglycemia, as well as hyperlipidemia. Increased blood sugar is because blood can absorb sugar from the diisolate. High lipids is caused by long-term use, which leads to hypertension. So a lot of complications. Kidney transplant is used to treat kidney failure, also caused end-stage renal disease, a condition in which kidneys can function at only a fraction of their normal capacity. The book talks about several different types of surgeries: nephrectomy, nephrostomy, urinary diversions. You want to make sure that you read through those just where you're familiar with them. People with end-stage kidney disease need either dialysis or a kidney transplant to live. Your kidneys filter everything, and if it's not getting filtered, it's going to build up, and that equals death. Currently, over 100,000 people in the United States are on the National Kidney Transplant waiting list. I will tell you the kidney transplant list, like you can't be an alcoholic, you can't be a smoker. There are several regulations with that. If it is that they're younger, they get bumped up on the list. If they're healthier, they get bumped up. They have to not smoke and not drink alcohol for so long. It's several things that go into when they get bumped up on the waiting list. And of course, they have to have blood type matching as well. There's 3 types of donors: living, non-heart beating donor, cadaver donor. So the living can be related or not, of course. Non-heart beating donor, this is someone who is declared dead by cardiopulmonary criteria. Cadaver, these are a match by tissue type. They also include assessment of blood type of ABO compatibility. Clients receiving living related donor is 90% kidney graft survival. Advantages, Advantages is some living donor transplants are done between family members who are genetically similar. A better genetic match lessens the risk of rejection. A kidney from a living donor usually functions immediately because the kidney is out of the body for a very short time. Some deceased donor kidneys do not function immediately, and as a result, the patient may require dialysis until the kidney starts to function. That's amazing to me that science has come that far. It's just amazing. To donate a kidney, you must be in good physical and mental health. As a general rule, you need to be at least 18 years or older. Must be consenting, of course. You must also have a normal kidney function, no hypertension, cancer, and no infection. Post-procedural, do labs assessment. You're going to check the blood chemistry, CBC, urine culture, blood typing, bleeding times. Pre-op meds is ordered. They will always get a prophylactic antibiotic, an immunosuppressive agent, which is like a steroid to help prevent inflammation and that rejection. The client will have dialysis 24 hours prior to the surgical procedure. This is to help increase the chance of graft survival. Blood from the live kidney donor is often transfused into the kidney. Blood from the kidney donor is often transfused into the client receiving the transplant. Let's see. Make sure the patient's skin is protected during surgery. Communicate with the family. You're going to monitor the urine output. Post-op vital signs, eyes and nose. Assess the urine odor, color, at least hourly. Monitor daily urinalysis for protein, white blood cells, red blood cells, specific gravity, and pH. Daily weights, your dry and your wet weights. Monitor fluid and electrolytes. Some of the major ones would be hypovolemia, hypokalemia, and hyponatremia. Monitor for fever, redness, and drainage. You want to monitor for early signs of rejection, which could be fever, hypertension, and pain at the transplant site. Provide urinary cath. Maintain irrigation to prevent obstruction from blood clots, which can damage the transplanted kidney. You want to make sure that you're removing the catheter as soon as possible. Give your medicine as ordered. You want to make sure that you give stool softeners. Just that way there is no straining. Then some of your patient education, which is very important, is make sure that they adhere to their anti-rejection medication, no contact sports, monitor for infections. They want a diet low in fat, high fiber with increased protein, and monitor sugar intake just to help with healing. So organ rejection, this is the most serious, hyperacute, acute, and chronic. Your hyperacute occurs 48 hours after the transplant when the antigens are completely unmatched, which can cause small blood clots to form in the transplanted kidney. It can also occlude the vessels. They will have fever, hypertension, and pain at the site. For this hyperacute rejection, the only treatment is removal of the kidney, unfortunately. Really sad. Acute rejection, this may occur at any time from the first week after the transplant to 3 months. Afterwards, up to 2 years. An antibody medicated response causing vasculitis in donor kidney. It starts with an inflammation. You'll have no urine or a low amount of urine, low-grade fever, hypertension, tenderness, and even fluid retention. The treatment is an increased dose of steroids or an immunosuppressive meds. Chronic rejection, this can take place over many years, which is crazy to me, but the blood vessels can become injured from overgrowth of smooth muscle. The blood vessels become fiber-optic. Yeah, with the cable company. Forgive me. Lord have mercy. There becomes scarred tissue over the normal tissue, which can cause kidney failure. Treatment is conservative. They will just monitor the kidney function. Ischemia is a delay in transplanting the donor kidney after harvesting. Kidney artery stenosis, just from scarring from the surgery or from whatever caused the end-stage renal disease. Infection, of course, you always want to do your good teaching on signs and symptoms of infection. And then also, if they have a thrombosis, a blood clot that forms in the major vessels, some of your nursing actions for that would be preparing them for emergency surgery, requiring removal of the transplanted kidney. You'll monitor and report any sudden urine output decrease. If they're having a decrease in urine output, it's usually from a stricture or obstruction from that blood clot. So you'll monitor that and make sure you document and chart real well. All right, so that is the end of the lecture. If you have any questions or if I've confused you in any way, please make sure you email me. Please, please, please look over your resources. Thank you.